Hi, I am Adrian, registered physical therapist, and with me is Alina. Today, we'll be doing an examination of the knee and surrounding areas. In examining the knee, the first thing I want to do is to observe the person's gait. Alright, so just walk to and fro for me. Nice, and walk back. And we're looking at how the hips and knees move together and also the ankle. We want to observe if there's any dropping in the hip to show weakness in the hip abductors, or we could also observe to see if there's any antalgic gait, seeing signs of pain or anything like that. Okay, when you come back up, I just want you to walk to and fro. Good. And in this position, when we're looking from the lateral view, we're looking to see if there's still an antalgic gait. I want to see if we're getting good extension and flexion at the knee. Alright, good, and stop and face so for me. Good. Nice. Legs apart. Come forward a bit. Nice, legs apart. Squat for me. And back up. And squat again. And you're looking at how the hips and the knees and the trunk coordinating together. Face right and squat again. You're looking if you're getting good extension of the trunk and if you're getting any amount of flexion at the hip and also at the knee. Okay, not bad. Very good. Face forward again. Let us try to look at the squat from a single leg perspective. Right? So while she's doing the single leg squat, we could see some unsteadiness, a little bit of lacking in trunk control, or we see some internal rotation and adduction at the hip and knee, which could be signs indicating risk of injury for things like ACL, predisposing to patellofemoral problems and all of that. Alright. Try to stand on one leg. Balance on one leg. So looking at the single leg balance, looking a little bit more now at the trunk control. Not bad at all. Additionally, you could ask the person to stand on an unstable surface. Repeat. And you're looking to see how that challenges the person's trunk and hip control. Not bad. Alright, so just stand with your legs apart. Now, we could take a more in-depth look at the alignment. So you just want to see at the trunk alignment and especially at the hip and knee. And you want to look at the knee to see if you're getting a genu valgum, a genu varum. You could also look from the side to see if you're getting a rectovatum or something like that. So you look at that, and also coming down, you want to see if the hips are internally rotated or the tibia is internally rotated. I want to look at the ankles as well to see if at the level of the foot, if we're getting flat feet, high arches, fallen arches, or arches are a little bit low. Good. Then moving from here now, we'll get the patient onto the bed next to do further strength testing and special testing of areas around the knee and some around the hip. Alright. So first one. Nice. Alright, come and sit at the edge of the bed right here for me. So from this position, we could do some manual muscle testing of the hip flexors, knee extensors, hip internal and external rotators. So bend this leg up like this for me. Hold it, don't let me move it. Very good. Then bring this leg down, straighten. Hold, don't let me move it. So testing the quadricep muscles and relax. And you could also use this opportunity to look at the bulk of the muscles as well to see if you have more atrophy on one side versus the other, especially after surgeries or chronic injuries. Hip internal and external rotation. Bring the leg in like this for me. Hold it in this position, testing the internal rotators. Good. Next position, external rotators now. Hold. Good. And relax. Additionally, sometimes pain in the knee, especially in the posterior aspect, could be caused by problems affecting the sciatic nerve or other nerve structures. So we could do some neural testing. So we could do a slump test. Let me this leg. And bending head down. And to see, you had any pain?
No.
Good. And we'll check these things on both sides. Lie on your back for me. For further neural testing, we could also do a straight leg raise. Any pain?
No.
Okay. and we'll check on both sides, right? Moving from here, we could also screen the hip to see if there's any pathology or anything happening inside the hip joint. So we could do a hip quadrant. With any pain of that?
No.
Because sometimes hip pathologies could radiate, causing pain to the medial knee. Moving from here, we could check the range of motion in the knee. A lot of patients after chronic knee injuries or after surgery tends to have a knee flexion contraction. So you could hold the legs up to see if the legs or the knee is falling into full extension, and that is what we're seeing here. Then we could assess active range of motion. Slide the legs up for me. Good, as much as you can. And back out. Nice. And you could also check passively to see if you're getting that normal, firm end feel. Good. So she's a little bit more flexible, so you get a nice, soft end feel there. But if you're doing the passives and you're getting an early hard end feel, that could indicate piece of the meniscus or something like that in the joint that could be blocking movement. So after assessing range of motion, we could do some amount of palpation. In palpating, we want to start with the anterior knee. So we could start with the quadriceps tendon. So that's just above the patella, feeling and checking. And as you go along, you could ask the patient if he or she is experiencing any pain. So the quadriceps tendon could come to the base of the patella, could come to the pole of the patella tendon itself, and also the tibial tubercle. Nice. Moving from there, we could check the lateral aspect of the knee. So in the lateral aspect, you could feel for the fibula, the head of the fibula, and then come up, and you're feeling along the lateral collateral ligament. You could come further here, and you're looking at the IT band, see if you're getting the patient getting any pain or anything like that. And you could also try to palpate for the lateral hamstring tendons. And also, you could look for Gerdy's tubercle to see where the insertion of the IT band is, if there's any tenderness there. Coming to the medial aspect of the knee, you could look at the medial patella joint line to see if there's any pain there. And you could also come along the MCL to see if you're getting any pain, and also the medial hamstring tendons. Additionally, we would like to also assess the joint line. So we put in some amount of flexion. It's easier for you to see. Hold the knee up for me. Very good. And then you come along the joint line, so on the lateral aspect, see if you're getting any tenderness. And you could also come and do the same on the medial aspect, checking along the joint line if there's any tenderness, which could be as a result of arthritic changes or meniscal injury. Moving from here, we could also do various tests for effusion. So we could do a milking maneuver, right? So you milk, nice, and then push back on the next side, or you could push up and see if the area refills. My favorite test to check is the patella tap test, which is much easier. So you could compare sides, and you could see if you're getting a soft kind of spongy feeling when you tap in one patella versus the other. Or we could simply do girth measurements and compare both knees. So in assessing the patella area as well, we could also look to see if we're getting nice patella mobility. And if the person had a possible dislocation of the patella, you could do a patella apprehension test, pushing the patella laterally and see if the patient becomes apprehensive or the patient complains of pain. Other areas which we could test for instability is the four ligaments inside the knee. So let us start with the ACL. To test the ACL, one of the tests I like to do is the Lappman's test. So we're going some amount of knee flexion there, and then we pull it forward. You're supposed to feel a restraint and a tug from the ACL ligament. If you're not feeling that, and it's more of a soft end feel, that could indicate injury to the ACL ligament. Could also do an anterior draw, and you're looking for that same firm end feel. And in the same position, we could also check the posterior cruciate ligament. So if the tibia is falling back on the femur, then we'll have a positive posterior sag sign which indicates PCL injury, or we could push back on the tibia to see if it translates posteriorly, which could indicate a positive posterior drawer test. Nice. Alright, stand up for me. We're going to change the position of the bed. Let's come and line it back for me. We could move now to check for the LCL and the MCL ligaments. So in checking for the MCL ligament, the medial collateral ligament, we want to put the knee in 30 degrees of flexion where it is the primary restraint to valgus forces. And then you're checking to see if the patient would complain of any pain or if you're seeing gapping in the medial joint line. Then we could put the knee as well in full extension and repeat. If there is gapping in this position, this could suggest a rupture of the MCL ligament along with damage to possibly damage to the ACL and the PCL ligament. We repeat the same for the lateral collateral ligament. Slight flexion of 30 degrees and we apply a varus force. In applying that varus force, if we see gapping or pain or the patient complains of pain, that could indicate a possible LCL ligament injury. We do the same thing at 0 degrees of extension, 0 degrees of flexion, and if there is gapping in this position and pain, this could indicate not only rupture of the LCL but also possible injury to the posterior lateral corner. From this position, I could also move to do a McMurray's test to check for injury to the meniscus. So you come up, internally rotate back out, come up, internally rotate again, externally rotate and out. Normally I like to just grind the joint a bit at various angles to see if I get any pain. Right. And then moving from here, I could ask the patient to lie on your stomach. To further assess the meniscus, we could also do an Apley's compression. You hold and you apply an axial load and you rotate the tibia on the femur. If the patient complains of pain, that could indicate a possible meniscus injury. Additionally, if we wanted to further examine the posterior lateral corner, we could do a dial test. So coming about 30 degrees of knee flexion, and then what we'll do, we'll turn, externally rotate both tibia. If we find that one leg is rotating more than the other, it could indicate that the posterior lateral corner is damaged in that knee that is rotating out more. Press back down. Moving from this position, we could also further palpate the medial and the lateral hamstring tendons and the medial and lateral head of the gastrocnemius. So medial head, medial hamstring tendon, lateral hamstring tendon and their insertion, medial head of the gastrocnemius, lateral head of the gastrocnemius, and see if the patient complains of any pain. If the patient is not complaining of any pain, then we could move forward to do some more MMT on the hip and the knee itself. So we could check the hip extensors. So lift this leg up for me. Hold, don't let me move it. Very good. Bend this knee. Nice, and lift up. Good, hold it, don't let me move it. Very good, and back down. Come up again, hold it right there. I will check the hamstring now. Hold, very good, and relax. Moving from here, we could ask the patient to lie on their side. On the side for me. I could quickly test the hip adductors and hip abductors. Lift this leg up to me, this one. Up, hold for me. Very good, and relax. Lift this one for me, up. Bring it in line with you, good. Hold, don't let me move it. Very good. And then moving from here, we could do the Opens test to check if there's tightness in the glute med muscles or the IT band. Come back and let the leg hang for me. And we see the leg is still up a bit, which could indicate some glute tightness. Nice. You can sit down for me, please. So there, we have finished our systematic orthopedic assessment of the knee and surrounding structures.